Welcome to the Pharmacy Quality Solutions Quality Corner Show, where we believe that quality measurement leads to better outcomes. Let us become your go-to source for all things related to quality and medication use in healthcare. We will hit on trending health topics as they relate to performance measurements and find common ground for payers and practitioners. We will discuss how the Equip platform can help you with your performance goals, and we will also make sure to keep you up to date on pharmacy quality news. So buckle up and put your thinking cap on. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. This is your host, Nick Dorich, and we welcome you to a new year. Like many of you, I'm looking forward to a year filled with positivity and promise. A year where we can help make things better and get back on track. 2020 came with its share of challenges, and in many cases, it was a struggle. Still, we are hopeful that the worst is behind us and that the future is ours to create. There's always a part of the future that we cannot control, but there are also aspects that we can impact. To get us started about things that we, as members of the pharmacy team, can impact, we are going to talk about changes for the 2021 Medicare Star Ratings. We thought we'd review some of the major takeaways related to medication use quality measures and what that may mean for health plans and pharmacies. Todd Sega, Pharmacy Quality Solutions' very own Senior Vice President of Development and Strategy, is with us today to go over some of these recent updates and to relay some noticeable state-level performance trends. Todd, thank you for coming back on the show.
Yeah, well, thanks, Nick. Thanks for having me back. It's great to head into a new year and get health plans and pharmacies working together and identify those areas of opportunity and improvement on many of the measures. So happy to talk about this because there's a ton of potential and look forward to talking about some of those trends and how that's changed.
Since we last had you on the PQS Quality Corner show, I know that some things have changed for you both personally and professionally. Do you mind giving us a status update on some of those items that you'd like to share?
Yeah, sure. Happy. Lots of exciting things happening. One of which is perhaps realizing that there isn't a need for so much sleep that you once thought you needed, but very excited to have two new children in our family. So we have two twins that came along, a boy and a girl, and we've been having a ton of fun watching them grow very quickly and going through clothes and diapers a lot more quickly than we ever thought, but having a lot of fun there personally. And then on the professional front, that was announced last fall, but very excited to continue working at PQS in a new role and succeeding Jeff Newell, our current CEO. It's been a great learning experience with Jeff and watching the company grow, but very excited to step into that new role with lots of excitement and enthusiasm for what we see before us. So those are a couple of the personal and professional related updates that I've been very excited about. So thanks for asking.
That all sounds great. We started this podcast hoping for positivity in 2021. And so far we're 2 minutes into the show and we're firing on all cylinders. All things are trending positively. So let's go ahead and talk about those CMS Star Ratings that I referenced earlier and updates for quality measures related to medication use. For our audience, I'm going to give a quick reference point, and the PQS summary of the 2021 Medicare Part C and D Star Ratings technical notes can be downloaded from our website, and that's pharmacyquality.com. From there, you can click on the Media and Education menu link for quick access to this and several other documents. Todd also did review the 2021 Star Ratings updates in a PQA presentation on November 19th, 2020. So if you listen to him at that point, this may be another review of that content, but we should dive into some additional context. Before we do jump into our 2021 Star Ratings update, it is important that we cover some very quick background questions. And Todd, this is going to be our first set of questions for you. So what are the Medicare Star Ratings? Why are they important for health plans? And then why are they important for pharmacies?
Yeah, sure. I think this is something that over the last few years that pharmacists, especially those in the community setting, have been learning a lot more about because of the programs that have hit the marketplace. And I think for many who haven't been seeing the cascading events of programs, accountability, contracting, and performance expectations from even the federal government, that it's easy to just see the trees, but not the entire forest of things. And so that's where it's been relatively new that we've been zooming out to see more of the forest, us being more so everyone in the community pharmacy landscape, because this has been an environment for prescribers and health systems that they've been more accustomed to for various performance or value-based reimbursement programs. But based upon some of the initiatives that the government being the Centers for Medicare and Medicaid Services, that center within Health and Human Services that has put forth through regulatory changes from the very beginning, a quality bonus payment demonstration project, which then came out of initially having a payment for prescription drugs. And that was in the Medicare Modernization Act. So there's a lot that's taken place over the last decade, but it's only the last few that we've been getting a lot more exposure to the star ratings because it's starting to have more implications for pharmacy. So to do that, it's always helpful to at least level set on some of the broader context for health plans so that we know how pharmacy has fit into that. So as I had mentioned, and I think one thing to call out that's really important, pharmacies don't get star ratings. There's a lot of confusion in the marketplace, and we hear from pharmacies all the time to say, how do I increase my star rating? Hey, I got my star rating of 3 stars. How do I make that better? Well, unless it's a specific program that has listed out that they will be assessing based upon that definition of a star, that has been using specific measures to then aggregate up to some sort of an overall or aggregate star rating, it's very challenging to say that a pharmacy gets assigned a star rating. It's not like you're going on to Google and looking at a star rating. It's easy. I think that's the life that we live in, where we look at the reviews for any Amazon product before we're going to get. It's simple. There's one rating that we see. It's good, bad, average, and then you can read specific reviews of them. But it's more than just subjective experiences with services or a product. There's a lot more that goes into a rating for a health plan. So that's the first thing to call out, is that pharmacies don't get those star ratings, but there is an assessment of performance that many health plans may have, or pharmacy benefit managers for different contracted programs, that will assess measure specific performance that may be defined as a tier 1 or a tier 3 or a specific star level. So I can certainly understand where there could be some confusion with that term, but to call out what that means for health plans, since they are the entities that get a star rating, it's also important to call out that health plans have specific contracts, and those entities are known as plan sponsors. So those specific Medicare contracts, it's not just a Humana or a United, but they actually may have 20 or 30 different product offerings, which each are termed as a Medicare contract. Each has a specific ID, and all of those are specific programs, budget lines, and products that they offer. And as such, come under some scrutiny from the government for that program, because they are offering a benefit on behalf of the government, and that benefit is Medicare. So to call out the difference between the two, we have Medicare Advantage with the prescription drug plan. So that's bringing in medical and pharmacy. And then we have the standalone prescription drug plans. So those are folks that may purchase a standalone plan on the side. They may get parts A and B from the federal government, but they'd like to pick up their own drug plan. There are lots of options there, but I want to call out that distinction, because among the Medicare Advantage with prescription drug plans, the MAPDs versus the PDPs, there is one large difference. And that one large difference is the accountability and the opportunity that the government places upon health plan sponsors. And that's in the form of a quality bonus payment. And that quality bonus of payment is assessing performance over a 12-month time period. There's typically a very large lag in the data. So it's about 2 years or so of when the star rating is representing the performance from that time period. So if you take a look at the 2021 star ratings, oftentimes that's really looking at performance from the 2019 calendar year. And it's called the 2021 star ratings because that's the enrollment year for which those ratings are applying. So there is a data lag that I wanted to call out as well. But as they assess performance, it's a complex statistical process that the government has for many measures. But essentially, there's a way to evaluate at a very specific measure level which then aggregates up to specific domains of similarly grouped measures. And then those measures roll up to a Part C rating. So Part C is looking at just the medical side. And then you have a Part D rating, which is looking at the prescription drug side. Each of those gets a star rating as well. And then if you are a Medicare Advantage plan with the prescription drug plan, as I mentioned, the MAPD, there's actually a combination of both that Part C rating and the Part D rating that roll up to what's known as an overall rating. It can be pretty confusing of all of the different layers, but all of that is done to be able to arrive at an overall rating, to get to that simplified set of stars. And based upon how those health plan sponsors perform compared to the rest of the marketplace, they are eligible to receive a quality bonus payment, which is usually assessed at a per member per month basis. And that's a huge opportunity for health plans, especially those that have a lot of competitors in a certain marketplace. Health plans that perform pretty well, that get a larger quality bonus payment, are able to offset premium dollars for future years. And that's what is typically one of the number one things that seniors look at when selecting a plan is affordability. So those that have lower premiums, and if they can buy down some of those premium dollars, it becomes a very competitive environment for health plans to perform well. But in order to get that quality bonus payment, those health plans need to control costs in a meaningful way, but also not jeopardize or skimp on the performance at a per measure, but also at a program level. So that's the biggest difference between MAPD versus PDP, is looking at the quality bonus payment. But beyond that, there's also a couple of other items. One of them is a marketing opportunity. So I think we've all been used to seeing the political ads, and we all know when it's the season for elections because we see all of the advertisements. And the same goes for Medicare open enrollment. So typically that's in October through December 7th, where seniors are able to enroll into a health plan for the future year. And if you are a 5-star plan, you actually have the ability to market your plan outside of that smaller window. So there's a huge opportunity there, since there are so many individuals, of course, turning 65 each day, and those that are in a lower performing plan, if there's a 5-star plan in their region, their county, where they would sign up for a plan, they actually are able to jump ship from their other plan and move to a 5-star plan. So that gives them an extended open enrollment opportunity, and they also can market and wave that 5-star sticker essentially in the air to let people know that they are a high performer. So there are some marketing opportunities there. Those are all carrot based, but of course there is a stick for some of those individuals as well. There is a penalty, and that is consistent again among the MAPD and the PDP plans, where consistent poor performance does lead to CMS having the ability to say you are no longer allowed to offer that health plan to those that are currently enrolled in your particular health plan. So they would have to send out the notice. It hasn't happened a lot, but there have been several health plans that have no longer been able to offer the health plan because of consistent poor performance. And that's typically 2.5 stars or less for 3 or more years. So it has to be consistent when they're performing well below the 3-star level. Then you get that penalty, and there's a notice that you have 1 more year to correct. But after the 3rd year, CMS has the right to essentially shut down that product. So those are some of the biggest background items. We covered the data lag. I think that's important to call out. The fact that pharmacies don't get star ratings, only health plans do, but based upon the PBMs that health plans may contract with, or for the health plans who contract directly with pharmacies, they may put forth programs that talk about various thresholds, which may have a star rating level to it, but formally, those ratings really are not assigned at the pharmacy level. So just wanted to call out some of those differences as well, but I think that takes care of some of the background items.
I think an apt metaphor, Todd, would be that so far, this is like the tip of the iceberg. Generally, they recognize that the tip of the iceberg is about 10% of the actual totality of that ice block. And with the Medicare star ratings, I see this as much the same. When you talk to a pharmacist or someone in a pharmacy about star ratings, it's yes, my adherence measures, but the star ratings program administered by CMS is so much broader than just these measures that we as pharmacists see in a traditional or typical community pharmacy setting. Now, I want to dive into that further with our second question. And Todd, you referenced for health plans and plan sponsors with PBMs. For a number of factors, they're going to be looking to improve performance for these measures, and they're going to be working with various providers, certainly pharmacy, but there's going to be other providers that may also be involved. So the CMS Star Ratings, these are updated each year, as you referenced, and this is based on quality improvement efforts and the impact that they have for patients in the Medicare program. These ratings help to highlight health plans that are high performing. But when it comes to what's changing for these Medicare plans, for the drug plan, so either a Medicare Advantage or for a standalone plan, there's a number of items that may impact their ability to be a 4 or 5-star rated plan. So do you mind digging a bit into, from the 2021 star ratings, what some of those 4 and 5-star plans look like, what thresholds for medication related measures may be appearing like for these programs in the 2021 star ratings?
Yeah, sure. I'll call out a few of those items, and there are changes year over year. And fortunately, none of those changes are surprises. Perhaps they're a surprise whenever they're announced, but the announcement is typically done through a notice of proposed rulemaking. So there's a pretty large runway for people to know about what changes CMS is considering for the program. And then it allows a public comment period for folks to share their concerns or support and thoughts for future rulemaking. So there is a process to receive feedback, which they take into consideration, and then they publish that final rule to know what will essentially be in effect for how things will be scored and evaluated for the following year. So there at least is some advance notice. And with that, I think it's also important to note that there can't be a brand new measure that's never been a star rating before to all of a sudden become a star rating. So there is a typical guidance that plan sponsors and CMS needs to follow, which is first a measure would be a display measure. Sometimes it's just uploaded if it's a patient safety measure, it's followed for some time, but every measure needs to be a display measure first for at least 1 year before it converts into potentially being a star rating measure. So there are some changes, but they aren't new. We know about those, and I'll talk about that maybe a little bit later if we have some time to get into some of those display measures and new measures that are in the pipeline. But one big item that we should take into account is the changing of measure weights. So not only does each measure get a star rating, but measures also have a specific weighting to them. Measures that generally are associated with improvement have a higher weighting. And in fact, there's one measure, which is a quality improvement measure, which looks at, of all of the measures that were assessed or scored, which of them had an increase compared to the prior year. So it's one thing to hit 5 stars or hit at a high level if you're a health plan, but your work's not done. You still have to maintain improvement year over year to score well on that measure, which is actually a 5-time weighted measure, which is the highest rated measure. So that's still key. Once people hit a high rating, you still need to keep pushing beyond that, which is what makes it very competitive and difficult for health plan sponsors. One measure that is having a change in weighting is the statin use in persons with diabetes measure. So that is a Part D measure. Certainly not the same, but there is a similar statin measure, but for cardiovascular use as a Part C measure, and that's statin therapy for patients with cardiovascular disease. That's an important measure as well. But SUPD is unique because for 1 year, it was a triple weighted measure, and that's what happened for 2021. So if you look at some of the key Part D related measures, and for 21, there were 14 Part D measures, and not all 14 are measures that pharmacies are going to be familiar with. As you had mentioned, Nick, they're probably most familiar with some of the adherence related measures. But of the measures, there are more common measures and those that are from the Pharmacy Quality Alliance that carry that triple weight which is the adherence measure. It was statin use in persons with diabetes. And if you add those up along with a comprehensive medication review completion rate, those measures account for almost 40% of that Part D summary rating. So while it's only a few of the 14, because of the weighting, there is a great deal of importance on those particular measures. So one of the big changes for MAPD and PDP, since it's a Part D measure for 22 and going forward, will be the shift from the triple weight down to a single weighting for statin use in persons with diabetes. And I think that came with additional feedback from health plan sponsors, and I don't want to say downgrading, but reclassifying the measure as an intermediate outcome to more of a process-based measure. And any process-related measure is typically a single weighted measure. So in addition, because it's similar in the fact that while it's different clinical guidelines, the end result is adding a statin. It's similar to statin therapy in cardiovascular disease. That measure is also considered a process-related measure. So it makes sense for that to represent a single weight. So that's one particular change. And if we look at some of the thresholds that took place, I mean, there's some great progress since the program has been in place on year-over-year improvement in key measures. But if we look at some of the changes in the thresholds, or at least at the 4 or the 5-star level, which is where the bonus payments start to take effect and where people are striving to hit, there was an increase, especially in the Medicare Advantage population when it comes to the 3 adherence measures. The 5-star level increased by 3%. So it went from 85% to be hit 5-star in the 2020 rating, so 2018 data. But with 2019 data for the 2021 star ratings, it increased by 3%. So that's a considerable increase, thinking year over year, to jump by 3%. Hypertension and cholesterol for adherence each also increased, but only by 1%. And then CMR completion rate had a 6% jump in that 5-star threshold. And then statin use in persons with diabetes saw a 4% increase. And we know a lot of resources and effort likely went into trying to improve that measure for the 2021 ratings, simply because plans were aware that that was going to be a triple weighted measure. So improving or performing well on that measure was going to have a higher likelihood or correlation to increasing the Part D summary rating as well. So we saw a lot of those changes on the 5-star, at the 4-star level. There were also some changes across the board. But I think one of the other key things to call out relates to future years. And the future years, we're actually planning to, I think it was next year, or even this year, I think it was the 2021 ratings, that is, CMS was planning to implement a new policy. And that new policy was going to be a guardrails policy, I think is how they've termed it. And that policy was set in place to limit the volatility of threshold changes, whether that was a 5, 4, 3, or 2-star threshold. A lot of plan sponsors were getting caught off guard and having some difficulty in achieving, despite great effort, these thresholds that were assessed or established retrospectively by CMS in the Star Ratings program, because some could have had a jump of 8 to 9%. So it's tough if you're aiming to be a 4-star or a 5-star plan, and then all of a sudden a threshold jumps 10%, but yet you improve by 8%. Some plan sponsors were sharing that it would be nice to have a ceiling or sort of a basement level to know that there would be a smaller range in which those thresholds could jump. But that is actually a policy that CMS is withholding until the pandemic is behind us, which we know all of us would like. But because of the unknowns that could be associated with performance related to the pandemic, they decided to not implement that policy so that the marketplace, if you will, would essentially self-correct. And if it needs to self-correct positive or downward for a threshold, then CMS has stated they would like that correction to occur in an organic way. And that's why they are removing that guardrails policy in case some measure thresholds need to self-correct down by greater than 5%, or certainly the other way as well. So that's a unique change as well to think about for prior years. And then there are some other pandemic related changes or considerations that CMS is making. And some of that relates to HEDIS measures and questionnaires. That's really evaluating effectiveness or experience of care from the member or beneficiary's experience and perspective. They are holding on some of those, knowing that the pandemic has likely created quite a bit of a hiccup in the typical process in data collection on those typical approaches. But most data-driven measures with claims or medical data, so prescription claims or medical data, a lot of those measures are continuing forward, but some of those other measures, if survey related, CMS is making some changes to that in light of the pandemic and the environment of collecting data. So those are some of the key updates based on your questions there.
There's a lot of changes, but they're all incremental, and that's an important part for a quality improvement process. To give a quick story, I'll have pharmacists or pharmacy teams ask about, well, hey, how do we improve 8 or 10% from one year to the next? And need to point out that that type of improvement from one year to the next, it's not going to be consistent. You can't improve 10% each and every year unless you're starting off as a really poor performer, right? At some point, you're going to hit that top mark. So it is important for the programs to have reasonable expectations for performance improvement, but you do always want to be trending positively and towards that higher end goal. Now, Todd, part of the process with quality improvement is that goals or thresholds are updated and evaluated each year. So while we talked about changes to the measures for 2021, what are we seeing with MAPD and PDP averages or scores? You already touched on some of those improvements, but are there any other changes to measures that could impact how they're evaluated as well?
Yeah, sure. And just so everyone's aware, from our perspective, we try to follow the measure specifications as closely as possible. And we typically like to use industry endorsed measures as opposed to custom or measures that are sort of randomly created. So especially for those clinical based measures, we always like to use measures from an endorsed perspective. So that would be the Pharmacy Quality Alliance and might be NCQA. And their HEDIS measures. That way it's a more objective and rigorous process. We know that the measure creation went through and that the results are reflective of an output that we know at least aligns with expectations for how the measure should be calculated. And that way it can be done consistently, data provider through data provider, so that the output is very consistent. So I wanted to just share that background, but as it relates to the measure performance that we've seen, it is pretty substantial. I'll try to describe this because I think it's best told through a chart, but in an audio recording, we have to translate that to description rather than what we see before us. So if we look at the measure averages, just looking at the 3 adherence measures, especially the RASA, cholesterol, and diabetes measures over the prior, let's say 10 years. So we're going back through 21 here, back to 2012, when data first started being tracked as a star rating measure. If we look at, for example, the PDC diabetes measure, in 2012, we had a measure average, and this is for Medicare Advantage, prescription drug plans, MAPDs, it was 73%. But if we jump ahead to 21, we're actually up to 84%. And while you may say, hey, that's only 11%, that's really not that much. It really is when you take into consideration how many millions of people. I'd have to go look at the latest enrollment numbers, but we're probably closer to 44 some million people enrolled in Medicare. And then for a measure like PDC diabetes, that's anywhere 20 to 30% of the population. So you certainly are getting a smaller set there. But over those years, we've been having so many seniors sort of age into Medicare every single day, enroll into that plan. Some might have been very poorly controlled patients or members with diabetes. And those health plans, pharmacies, and prescribers have had to work together to try and correct or create some new behaviors. So when we think about that shift going from 72 or 73% up to the mid 80s, and that's actually quite consistent for all 3 measures except for cholesterol, which actually started down at 68%, and it's now up to that 84% range for a measure average. That's a really big shift. to change locations. So we're talking about tens of millions of people that were converting from not taking their medications at least 80% or more of the time that are now doing so. So we're actually getting to some levels here that are really starting, you have to almost wonder, are we topping out on some of the measures? And I know CMS has had some specific thoughts if they're not seeing distinguishable performance among different areas in the country or even within the same area across different health plans, then that might be a consideration that they have to think about even retiring a measure, moving it from a star rating to a display. But despite all three measures having a measure average within 1% now, and we're in the mid 80s, there's still some distinguishable performance in different health plan sponsors. And that's the reason why we have larger ranges among 5, 4, 3, et cetera, threshold levels. So it's going to be interesting to continue following this, but the performance swing has been quite substantial. And when we get to standalone prescription drug plans, it was a similar trend, but we did start a little bit higher at a baseline in 2012. But measure averages are actually about 1% higher. So they're about 85% for both PDC, diabetes, and cholesterol. And then we saw another % increase in the measure average for PDC RASA. And with that, the measure average is actually up to 87%. So that's the highest in history that we've seen. And it's been a pretty upward trajectory for most of these measures in terms of the averages that we see year over year. So I think that'll be interesting to watch. But again, these are part of a bigger picture, not just one measure. Each measure gets a star rating, but those roll up into those domains and then summary ratings, as we mentioned. And so as the puzzle pieces fit together and we get up to the very contract level or that product level that seniors would see if they go onto the Medicare Plan Finder, there was actually a slight decrease in that overall star rating for MAPD plans. And then for standalone prescription drug plans, while the average stars increased, there's still some pretty low performance across the board. So there are actually fewer enrollees in the 2021 contracts that were in a plan with 4 or more stars. And I think it was less than 20% of enrollees are actually in a PDP contract that had 4 or more stars. So despite seeing some of these high measure averages, there's a strong opportunity for improvement on some of the other measures in the program. And as such, they being the health plans are going to continue looking for various providers, prescribers, pharmacies, and groups that can help coordinate care and try and achieve higher performance on many of these key measures.
Thanks, Todd. The short and sweet version or summary for this is that those measures and measure performance, the indicators are that CMS continues to push those thresholds. As you said, there's still discernible difference. There's still opportunity for room and for growth. But as CMS looks at other measures, there may be some changes to measures that are in the program, new measures that are brought up. So it's important for pharmacists and for pharmacy teams to still stay focused on these adherence measures and what they can do to impact performance for those measures. But there may come a time in the not so distant future where more measures like statin use in persons with diabetes, more measures like that related to gaps in care, or clinical guidelines where they may be more applicable. Before we close, Todd, do you have any other high-level bullet points that the audience needs to know about future considerations or changes for the star ratings that we may not have already covered?
Yeah, sure. I'll share a couple and then hopefully another, just as you started with some positivity for 21, I'd like to paint some of that picture for what's on the horizon for us. And the first, that is something for us to just be aware of so that we aren't thinking in 1 year intervals, but as this has been a newer concept for pharmacies in the last few years, I think it's important for us to think upstream a little bit further. So we have the measures that are here and now, but what might be coming so that we as a group of pharmacists and pharmacies in those corporate groups aren't surprised when a new measure comes our way. So if we think about the bench and getting into the game, it's easy to just look at the display measures. I often think about those as being on the bench. So if we think about some of those that will be forthcoming, we have a measure on patient safety looking at concurrent use of opioids and benzodiazepines. And then the Pharmacy Quality Alliance actually has 2 measures that are sort of a replacement or very similar because they worked with the Beers List and the American Geriatric Society and the creation of the measure, similar to how a measure was in the past, which was high-risk medication use in the elderly. That's probably going to be a retired measure. After this year, it will no longer even be on the display page. So what's thought of as a newer age high-risk medication use measure are the two polypharmacy measures. And there's a measure looking at the use of multiple anticholinergics. And then there's also multiple CNS active medications. And those each are their own separate measure, knowing that both can increase fall risk and other complications, especially in older populations. So those are two measures to be aware of, so there are no surprises when they come our way. And then the last item to leave you with, which I think is a very nice positive, is the consideration and broader outlook beyond the measures that we've seen in the past to the type of programs and considerations that health plans are having and working with community pharmacies. So we are in a different environment, as everybody knows, and we have an environment where many being patients, have been foregoing routine medical appointments, whether that's with their primary care provider or follow-ups with specialists for chronic conditions. A lot of people have been avoiding that care. And as those individuals look to follow up or reinitiate in person, for those that weren't comfortable doing telehealth, there's going to be a lot more activity in 21. And the system was already overwhelmed thinking about the physicians that we have and the availability for appointments. So there needs to be a broader view, and it needs to be a more creative way to think about how do we manage and treat chronic disease in the country. And while all of us in the pharmacy side have been pounding our chest saying, hey, look at us, I think we are capable of doing all of this, not many of those opportunities have really been given to us. So I think we're going to see a lot more opportunity come our way in the next 1 to 2 years than we've seen in prior years. And I know we were really excited to support a partnership with a payer and groups of pharmacies as it related to diabetes under control. So it's starting to tap into the medical side benefit. And that's where I think pharmacy has talked about for many years about the expenditures that we can help save on the pharmacy side, but have those savings truly translate over to medical savings and avoidable expenditures, whether those are ED visits, routine care that's avoided, and we have people hitting goals on blood pressure and diabetes, things like that. So there's a great opportunity for more outcome-based programs, and we're seeing a lot more interest beyond even just Medicare in unlocking the potential of community pharmacies to work on programs and measures that are actually translating beyond prescriptions, but how that side of the benefit can truly offset expenditures on the medical. So lots of opportunity there. And we like to think of the adherence measures and some of the measures we've been more comfortable with over the last 4 or 5 years as a bridge, getting us to more of the outcome-based measure or intermediate outcome-based measures on the other side of it. And that's a whole new world for us. So it's going to be a strong opportunity as these programs continue to go forth for pharmacy to step up and show just how well they can adapt and be agile and make an impact on measures beyond adherence, but truly make an impact on those outcome-based measures as well. So I really do feel confident we'll see more of those programs over the next 1 to 3 years. And that's a lot to look forward to.
Earlier in our recording, Todd, I referenced the tip of the iceberg, and that being just about 10%. And adherence measures are truly the tip of the iceberg for pharmacy and quality improvement efforts for patient care. But we've covered a lot of content for today, and I do want to get us wrapped up. And we've shed a lot of information about the 2021 Star Ratings and the updates contained there. But Todd, a bit of a personal question for you in 2021. Do you have any new big New Year's resolution or something that you'd like to enlighten us with about how you're planning, how you in particular are planning to attack this year differently?
Well, as a large fan of The Office, I will say do a cartwheel, then I can be done. But on a more serious note, I would say that in reflecting back on the year, there's an opportunity to read more. That's something I like to add to the list. And then something simple like drink more water. I even have it in front of me, but yet I get distracted and I don't drink the recommended amount of water each day. So it's such a simple thing. And that's high on my list as well. So to be healthy with water, but also being able to be a lifelong learner and read some books that I've been meaning to read that have been backing up. And you'd think I'd have more time with the pandemic and being at home a little bit more, but it's harder to do that, especially with 2 newborns right now. So I'm hoping I can dig deep to find some energy to read that. So those would be 2 resolutions on my side that I'm looking forward to in 21.
Thanks for that, Todd. And thank you again for helping us start 2021 on the Quality Corner show. And we look forward for your next visit on the show. And I think that'll actually be pretty soon. I think you'll be back to talk about the PQS trend report in pharmacy quality. And that actually is going to transition us throughout January 2021 as we're going to focus our next series of podcasts on opportunities for pharmacy. This started with today's updates on the Star Ratings program, as we know that pharmacies and pharmacists are the healthcare professionals best suited to impact measures related to medication use. But over the next few episodes, we're going to cover some of the key findings from the 2020 PQS trend report. And Todd, you had a big hand in that. We'll talk about the consumer or patient perspectives about pharmacist provided services. We'll then go into pharmacy readiness to provide advanced clinical services. And finally, we're going to end with the payer perspective and how they see an opportunity for pharmacy to become a more integrated member of the care team. Todd, you referenced that with outcomes-based measures. So a lot of great information that we'll be happy to dive into and get everybody excited for new opportunities in 2021. This series is also going to include a number of external guests that will bring key insights to the trend report, and they're going to help us identify some of those key findings that you can look to implement with your pharmacy practice. So I'm very excited for you, our listening audience, to listen to this new series. And until then, I would recommend you check out the trend report, which you can find on the pharmacyquality.com website. So until then, we do have one final message from the PQS team.
The Pharmacy Quality Solutions Quality Corner Show has a request for you. Our goal is to spread the word about how quality measurement can help improve health outcomes, and we need your help in sharing this podcast to friends and colleagues in the healthcare industry. We also want you to provide feedback, ask us questions, and suggest health topics you'd like to see covered. If you are a health expert and you want to contribute to the show or even talk on the show, please contact us. You can email info@pharmacyquality.com. Let us know what is on your mind, what we can address, so that you are fully informed. We want you to be able to provide the best care for your patients and members, and we wish all of you listeners out there well.